special consideration in pediatrics, right? The time frame for analysis and activity is a lot less than adults. Adults, we reevaluate every 2 minutes, But in pediatrics, in newborns especially, we like to keep it short. So 30 seconds, 30 seconds, 30 seconds. Is this happening? Is this happening? Is this happening? Sawa. Okay. What's another thing that changes with newborns? What do you think? Newborns versus adults, what else is different? Compression rate, right? So we do a rate of 3:1. 3 compressions, 1 breath. Good. Adults, it's 30:2. Okay, good. Another thing that's different? Position of the head. Position of your head. You have to position your airway in which position?
Newborn. Neutral position.
Okay, neutral. Sawa. Good. Another thing that changes? Depth of compressions, yes. Adults, you go like 2 inches. These ones, you go 1.5. That's correct. Yes. Sizes of everything is different in pediatrics. You can use one standard size of your BPM for adults, but newborns is a special one. Pediatrics is a special one, and then adults is a special one. Sindio? Yeah? Okay. Newborn infant. See how tiny it is? Pediatric. See how still small but not. And then adult. See the difference? Yeah? Okay, good. What else is different? What else? Another difference? Okay, what do you mean? Oh, yes, good, correct. Hand placement, perfect. So you can do 2 things for newborns. Which ones? Tell us. You do that. 2-finger technique, cha, or 2 thumbs and suckling technique. Good. Something else that's different? Dosages, right? Everything is weight-based. One of the first things we do when we're receiving a baby, weight them. Yeah. Okay. All right. Then we talked about another thing. Babies need to eat very, very fast. We have to give them more. Some of the ways they need to eat, all of those. So we dry and keep warm. Okay. Good. Angie is going for it. Okay, this is what we were talking about, the hand placement, right? The 2-hand encircling technique on your left, and then the 2-finger technique. Where are we placing in both of those? Where is the point of compression that we're going to be at? Put it in the stomach. So, where? So, nipple line, center, and then slightly down, but above the ziphistanan at the center of the chest. That's the same as adults, okay? Sawa. You hear that sound? So, that depth is 1/3 of the epi diameter. It's about 1.5 inches. So, everybody's going to practice these ones. And I want to hear that sound. I don't want to hear. That's nothing. I want to hear. Sawa. Okay. Haya. Another modification. If you're going to feel the pulse in a different zone, that means that you can get a different IV access. Don't you think? Ama, we just look for a yellow line, we struggle. We prick baby 50 times looking for a yellow line. Ama, is there any alternative we can use for a newborn? Yes, umbilical, vein, catheterization, right? There are some models going around. If you have a look at it, looks like a Mickey Mouse. So it has the two small ones at the top and one big one at the bottom. That's how it will look like in the baby. There'll be one big one at the bottom that's collapsible, and then the two arteries. So we cannulate the vein, the bigger one at the bottom. Okay. And you can use an feeding tube. See, these are things we all have. Yeah. So feeding tube, size 5 French, gauge 5 French. It will fit very nicely in there. Sawa. Okay. Video. So we'll watch a short video on how UVC is done. Okay? So that you understand how it's done. Please practice at your center. Please. Okay, let me see. Yeah. Sorry. So just read the steps. They're at the bottom. So first they clean with spirit and betadine at the bottom.
Cover the abdomen with an eye towel.
Then you cover it because it's a sterile procedure, okay?
Base of the umbilical stump.
See, there's usually a clamp over here.
Cord straight
So just under the clamp, we want a tie,
horizontally.
and then you cut in between,
Surgical blade.
okay?
Tighten the loose knot.
Then you'll be able to see this.
Identify
You
the
see?
umbilical vein, which is usually
Right?
of a larger caliber.
You can see the vein?
And at 6 o'clock position.
Okay, great. Then you take your feeding tube, size 5 French, you load it and prime it
Saline
with some normal saline before you come here, okay?
an umbilical catheter
Once you've primed it,
or 5
then you
gauze
can
is used for preterm baby.
insert it into the
Introduce it
vein. Slowly too. Keep going. Not too deep.
easily. You should not feel any resistance.
Yeah, should go down very easily.
And good
No
backflow of
resistance.
blood confirms the
Then you
umbilical catheter
aspirate,
is in the right
okay?
position.
You'll get some backflow. So you'll be knowing it's in the right position, okay? And it's ready to use. You just secure it nicely, right? And it's ready to
You would
use,
remove the catheter.
okay? That's how, imagine it's that simple. So it's something we can all do. Okay. Now, after we've done all of those, yes,
So after you insert it, you don't strap it.
you have to secure it, yes. Yeah, you can still use strapping around the site. So how many have gone to the IO, intraosseous needle station? Okay, basically you pad it at the bottom with some gauze, okay? And you strap the side so that it doesn't keep moving around. That's about it.
Strapping the stump, you're not
Just the
strapping
stump, not necessarily the cord, no. Yeah. Sawa. In other centers, they have an actual UVC set that has all the things, but us, we can modify. Sawa. Okay. So, we've told you the modifications, right? So now we have to actually resuscitate these newborns. Angie. No, it's you. Yay.
Mine is very simple. So we are going to.
So you remember that baby from the whatever over there? Maternal resuscitation. Sasa amefika kwa midwife.
So we are going to put what we have done to practice. We can now like 3 groups. One there, one here.
Take them through the algorithm first. First, we'll go through the algorithm. So everybody open either your app or your algorithm to chapter 4, neonatal. We just have a look at how it's done. To see if we've been doing the right thing. Sindio, everybody open your app or your algorithm.
Okay. So we are ready. So a baby is born and you are the one receiving the baby. What do you do? What did he say we need to do? First thing is to you need to warm the baby. So you wipe them and remove the wet clothing. Then after wiping, what do you do?
As you are wiping, you are looking for response.
Yes, you are in a way stimulating them so that we can see whether we are going to initiate the spontaneous breathing. So you have warmed your baby, you have wiped them. They are not responding. What else do you do?
Tell me, I'll do it as we go along. Yes, so I've received my baby, I've wiped as I'm stimulating. What else am I doing? Exactly, true. Then you get another cloth. Okay, I'm assessing the breathing. Okay.
Okay. So next we check the airway. If you can see any fluids, you need to suction. And how do we suction?
There's a bulb.
Bulb suction. And where do we start exactly? From there? You suction the mouth, then you go to the nose. So.
Okay. Let me do it physically. So, you said? Okay, good. We've sucked. Good. Then?
So the baby is still not breathing. What do you do next? Before we bag. How do we start bagging? We check for the pulse. And we say the pulse, we need to check it where? At the umbilical. So you check your pulse. It's below 100. What do you do? Start the resuscitation. How do we start resuscitation? Heart rate is below 100. We give? We bag. So we use our BVM to give that positive pressure ventilation. And how are we bagging this patient? Tuko na algorithm. Tumeshika. One breath. We are ventilating 40 to 60 breaths per minute. So per second. Sindio?
Okay, good.
So we have bagged our patient, checked our heart rate, is still below 100. One breath every second. So what is the next one?
Then you do what after that? So I've bagged.
Heart rate is below 100. We are bagging. What do we do? We?
Then you? So we are over here. We've done our bagging. Sindio? Right? Okay. So with bag valve ventilation, we've read that it is at a rate of
40 to 60
40
breaths.
to 60 breaths per minute, okay? You're doing this for, you remember, 30 seconds. You see that on the side of the algorithm? So you do this for 30 seconds, then you reassess. Okay, when you're reassessing, you're looking. Are they breathing again? Are they having apnea? Are they having gasping? What is my heart rate also? Is it still below 100 or has it come up or not? Has it gone below 60? Okay.
So it is below 100. What do we do next?
So it's still just below 100 but above 60. Okay. So
We consider to intubate our patient.
So
Okay. And also, as you consider to intubate your patient, you check the ventilation corrective steps.
So you ask yourself, am I bagging adequately? Is there good chest rise? Is it leaking too much? You know, things like that. Have I positioned my airway correctly? Okay. You have to keep readjusting as you're going. Sawa. Okay. So you do that for another 30 seconds. If you have the ET tube, good. Just intubate at that point. If you don't, keep bagging. Sawa. Okay. So we do that for another 30 seconds. Then we
Our heart rate is 60 beats per minute. What do we do with CPR? At what rate? 3:2. And we said we do it 3:1, sorry.
Okay,
so we are doing the 2 thumbs and cycling. 1, 2, 3.
And then the one is for bagging. Good. So one breath, ensuring this chest rise.
3.
1, 1, 2, 3. 1, 1, 2, 3. 1, 1, 2, 3. 1. And you continue doing that as you have to make sure somebody has come to help you, because this is where we are starting to put our UVC. Sawa. Okay, because we are thinking, baby has been down for a while. So it's been like 2 minutes now, right? As you go down the algorithm. Baby has been down for a while. I've started chest compressions, but I might need some additional drugs. Okay? So you need somebody else to come help you put the UVC. Okay? Because you want to give adrenaline. Chop, chop, chop. Okay.
So how much of adrenaline do we give? 0.1 of?
0.1 mils per kg of the 1 in 10,000 concentration. How do you make 1 in 10,000 concentration? Does it come like that? No. How does it usually come?
1 milligram.
1 milligram is usually what concentration? 1 milligram. So I agree. 1 ml, 1 milligram. Good. I agree with all of that. Perfect. But what is the concentration in terms of the ratio? 1 is 1,000. Sawa. So how do you do the 1 in 1,000 to become 1 in 10,000? You add 9 mils of
normal saline.
And this is the solution that you will give us 0.1 ml per kg. So if your baby is a 3 kg baby, how much are you going to give? 0.3 ml of this solution. Sawa. Now 0.3 in a 10 cc. How are you going to give us? You can use a 2 cc syringe, okay? Or a 1.5. Okay, yes. Which other? What if your baby is a 2 kg unit? Newborn. 0.2 ml. What else can you use? So very small measurements. Insulin syringe, exactly, right? Because that one has to the mils, like very small. Yeah. So these are things you have. Have you ever thought to use an insulin syringe to give adrenaline to a newborn? Yeah. Now you know. Okay. So for all your pediatrics newborn resuscitation, you use 1 in 10,000. Are you clear?
1 is to 10,000 by different 1 meal.
Yeah. You give the whole. Anyway, okay. We're clear. We're clear up to there. We're together up to there.
I was just asking about the insulin syringe.
Yes.
Because it's only calibrated in the national units.
It is a 0.5. It's in mils. Very tiny mils. It can give you these small measurements. Yeah. It's not in. It's in ml. Iron. Sawa. We're together. We're together. Yes. So you see, it's a step-by-step slow walk. As much as we're describing it as a slow walk, it's 30 seconds. Cha, cha, cha. One action after the other. Okay? Once you get down to this point, you see how it says, consider hypovolemia, consider pneumothorax. Because we've been bagging, right? And we are big adults. We like using force and squeezing everything in there. there, and they have very delicate lungs. Okay, so they could have gotten a pneumothorax. Okay, and it's very characteristic. You'll see patients babies who initially you give your breaths, they start picking, the heart rate starts coming up, then all of a sudden you reevaluate again and it starts going down, down, down. Likely there's a pneumothorax. What's another thing that you have to do at this point?
Sugar.
What if it's a mother who had gestational diabetes and they've had a 5 kg baby, hypoglycemia. So even newborns get an RPS. Sawa. Okay? Yeah? So newborns, all babies get the same thing as adults, just a bit finer tuned. Okay? So let's run through the algorithm one more time together, and then we can each of us go into the small groups with the babies. I think we have like 5 of them. You can practice the compressions and everything. So we said baby is born. The first thing you do when you receive them, you start drying them as you're simulating and you're analyzing the APGA score. Yes. Then you change your clothing, make sure you're in a warm resuscitator. Yes. Okay, so that's 30 seconds, you've done that. Then you're like, is my baby breathing? Yes or no? Is my baby gasping? Yes or no? What is my heart rate? Is it below 100, above 100? Is it below 60, above 60? Okay? If they are not breathing, or if the heart rate is below 100, you start with bagging. Okay? Not to forget that you suction if there are any secretions. Okay? So you bag 1 breath over a second. Sawa. Yeah? Ideally, if you do this over 30 seconds, you give 30 breaths. So, ideally, you're giving 30 breaths. Sawa. It's easier to go with a higher number of 60 than the lower number. So, okay, good. So you do that for another 30 seconds and then you reassess. Okay? Maybe they're still not breathing well on their own. The heart rate has not peaked. If you're in a high resource setting and you have the capability, you can't intubate. Okay? If you're not, you continue bagging. Okay? Good. You bag for another 30 seconds and you pray, oh, please, baby, please pick a bag. Right? You're like, help, somebody put for me what? UVC. Sawa, because I need to give drugs. Sawa.
So when you're
Next step will be drugs.
That's where you put your
That's why you put your UVC. Yes. Sawa. Okay.
I'm talking about 1 breath after every second or
Yes.
1 breath after every 2 seconds.
There's a range. You choose one.
40 or 60.
You either choose 40 or choose 60. For me, 60 is easier to remember.
Better.
And isn't it easier to do 1, 2 breath, 1, 2 breath. Which one is easier?
1.
1.